start the webinar. We're really excited because today is a cardiac theme and we've got two really brilliant speakers, and I'm going to allow Marty Viecha to introduce them in a second. So my name is Mignon McCulloch, and I just want to introduce you to our what I think is a wonderful new website. The web address is pediatrics.org.za, and we would really like you guys to consider becoming members, no matter what level of pediatrics you're doing. We're trying to make this website an interactive forum where people can meet like-minded people. We would like you to put your name forward if you're interested in part of being the executive committee as the elections are coming up. And we also want to remind people about the SAPA virtual Congress from the 13th to the 15th of August. So lots of good news. And if you can't remember all of that, please visit our new website, and I will remind you and give you the address again halfway through the presentation. So over to Marty for you to introduce our great speakers today. Thank you, Marty.
Thank you so much, Mignon, and thank you for everyone that's logging on at the moment. We are very excited about this cardiac webinar today. So first of all, I'd like to introduce Prof Steve Brown from the University of the Free State, and they are doing amazing interventional cardiology procedures in their cath labs, and I'm very privileged that Prof Brown was one of my undergrad teachers. So I am really privileged to have him on this talk today, and I think he can plug about any hole in a heart in his cath lab, and I am really looking forward to this great presentation. Thank you so much, Prof Brown. It's over to you. You can start sharing your screen. I've stopped screening, so you can start sharing.
Super. I'm setting it up. Whilst we're doing the setup, I want to thank the committee and Marty and everybody for allowing us this opportunity. That's it. It should be full screen now.
All good.
Thank you for this invite. I sincerely appreciate it. And I was thinking a lot today when talking about interventional cardiology. So instead of kind of like trying to show you everything we do, I think let's rather be a bit more practical and look at the newer kind of like procedures. And I've also tried to make it practical and simple, so bear with me. We're basically going to have a quick look at PDA closure in small infants, where we're going with PDA stenting, and then of course my real pet subject is the percutaneous pulmonary valve replacements. Now, I want to start off with this. You know, everybody thinks, and it's actually true for all physicians, this is the 2015 World Cup opening in England, and it looks so great and fantastic, but the reality, in fact, is somewhat different. It's tough. Medicine is not always perfectly well defined, and it's hard work, and nothing, especially in pediatric cardiology and interventions, are ever that simple. But let's have a quick look at the ductus arteriosus. Now, the older I get, the more interested I am about history, but it's interesting that in the 1st century, it was already described by Galen, of the vein of Galen kind of like fame. The PDA in low birth weight infants is actually very common, and it occurs in up to 77% of infants less than 1,500 grams. But I think what's even more important is that almost 94% of PDAs will close spontaneously within 2 months. So without us ever doing anything. And on the right-hand side is the so-called Krichenko classification, which is important for us as interventionalists because the anatomy determines the nature of the device. But I think it's clear that the ductus arteriosus is a very complex structure. And I just want to briefly just have a quick look at what happens in fetal life. And it's quite interesting that almost 65 to 80% of fetal flow goes through the right heart and the ductus arteriosus. And it's being kept open by a very complex interaction between the placenta and the endothelium involved in the wall of the PDA. But looking at the anatomy after birth, and that's what's important. This is the lumen of a full-term ductus, and one can see how thick the wall is. Also, it's vascularized in the outer layer. Compare that to the preterm ductus, and one can see there's almost no vasa vasorum in the outer layer. So it basically gets all its nutrients directly from the lumen, and that probably is the reason why it is so unresponsive to some of the therapies that we use. So the duct is very complex, but what does it do in a preterm if it is hemodynamically significant? And these we all know. It gives rise to increased incidence of intraventricular hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, as well as pulmonary hemorrhage, and then numerous other smaller irritating, and I would almost say like harassment of the poor pediatrician and neonatologist trying to deal with this big duct. So when we try and to assess and decide, should we close the duct? I think it's very important to know actually when not to close the PDA. And for me, the question, and I always ask, is why is this PDA remaining open? And to put it in medical terms, is the duct pathological or not? And we know the ones that we would most definitely avoid would be any ductal dependent lesion, and then obviously children with pulmonary hypertension. And I just want to point out two that lesions that one should always be aware of. If the duct remains open, you have a slightly big right heart, and that's coaptation and aortic stenosis. And especially if it's critical, the duct cannot do anything other than remaining open because the baby needs this to maintain systemic flow. So I think one has to be very certain before, first of all, when one decides to close a duct, is it really necessary? And one has to be certain when one embark on this road that there are not underlying pathology that should be excluded. But how do we then assess a duct to decide, is it hemodynamically significant and should it be closed? So I think we are all still clinicians, and even though it's non-specific, there are still very important markers. And one of those is a low diastolic blood pressure. And people tend to forget that PDA shunts both in systole and diastole, but this very low diastolic blood pressure is actually a guide to show one that this is quite hemodynamically significant. And obviously the ones that we get consulted for most frequently would be problems with ventilation, weaning from oxygen, etc. But when we assess it echocardiographically, one would look at it from a number of angles to decide that this is a hemodynamically important duct. And one would look at the anatomy, whether there's signs of volume overload, and then systemic shunt effects. And I briefly would just touch on diameter, which is self-explanatory. The bigger the duct, obviously, the more significant. And direction of flow, where we can either use color Doppler or pulsed or continuous wave Doppler, very important, and to detect any bidirectional shunting, which would once again be a contraindication to closure. And then volume overload, looking at your left heart and left heart structures, if they are enlarged, there's definite signs of volume overload, and then more specific pressure overload, and that's more pertaining more to our Doppler dysfunction of the left heart. So once we've decided we have a number of these, one can decide then what should one do. And there are actually now for neonates and preterm infants quite a number of strategies. Now, I've already alluded to just being conservative. Quite a number of them are not pathological, not causing any harm. And sometimes it's better just to leave it and let nature takes its course. However, our other options would include the pharmacological options, and then surgery, which often takes place in the neonatal ICU. But there are a number of complications associated with surgery, including in prolonged ventilation. And we've had quite a number of children with chylothoraces, etc. So where do we come into interventionally? Now, we are very fortunate. Quite recently, a new device has been released called the Piccolo occluder. Now, it's indicated for infants or any small infant over the weight of 700 grams. And the reason for that being that your vascular system to place these devices goes through a full French sheath, which is quite small. And these devices come preloaded, making it simple and easy. So this is what the Piccolo device looks like. It comes in 3 different sizes of the waist. It's basically 3, 4, and 5 millimeters in diameter, and then in 3 different lengths, 2, 4, and 6 millimeters. But it's actually a very, very small device. It's also very soft. And the question is it safe? That's the bottom line. I'll show you now examples of where we used it, and we've had good results. But there's been a beautiful study published in May 2020. And this is the group of infants where they implanted these devices with market success. And you can see it's the whole spread from 700 grams up to almost 2 kilograms, and quite a wide range of gestational age infants. So we know it's quite doable, it's safe. But what's interesting is I've alluded to the Krichenko classification, but if you look at the fetal duct, quite a number of ducts in premature infants are the so-called group F, or the type F fetal duct, which has almost a hockey stick deformity. And most of these infants less than 2 kilograms actually have this kind of like PDA. But it's proven to be successful in the majority of types of PDAs in infants. Now, this is the basic idea of what one does when one implants the device. So the device gets implanted, but it does foreshorten as time goes by. And also when the volume load gets taken off, relative to the anatomy, the device may get bigger. So it's very important to select the correct device, because one of the complications may be that the left pulmonary artery may be jailed, especially if we select too long a device, or alternatively, one may develop coarctation of the aorta. So what does it then look like in real life? So this is a real prem we did. It's a 850 gram infant, lots of problems with ventilation, couldn't wean off the ventilator, recurrent chest infections. And why I'm showing this is, this is why I showed the rugby field in the beginning. This is trying to delineate this fetal duct. And this is a full French catheter, and you can see how big it looks just compared to the pulmonary artery. And eventually we kind of like could demonstrate the anatomy. And it was almost like the hockey stick deformity with a narrowing at the pulmonary artery end. And this is the device coming in. Now, this is the scary part for us as interventionalists. And this is a premature infant. And this is what the small device looks like. This is a 4 by 4 device, so 4 millimeter waist and 4 millimeters in length. And then one deploys it, and I apologize for the quality because the problem is the device, the metal is so thin. It's also quite difficult to see on radiology, but one can see it's still attached to the cable, the aortic end over here and the pulmonary artery end. And this is what it looks like after release, and we had quite a good result. And we've done now about 12 to 14 children with this device. And I think it's a very good option in low birth weight infants, especially because sometimes it takes a while to get the child to surgery, all the risks that we've mentioned. But having said that, any device that we implant is never without risk. And one must just remember that the transport of the infant, the child may cool down during the procedure, very important. I've mentioned and alluded the complications of pulmonary artery and stenosis and coarctation. And then embolization, these devices may, like any other device, embolize. We haven't had one, but looking at the literature, because it's so small, it's quite easy to retrieve, provided you have the correct equipment in your cath lab. So I think this is one of the new methods. We can intervene a little bit sooner if necessary, and if it's available in one's cath lab. So it just gives us a new modality of treatment for preterm infants. I want to move over to ductal stenting now. This may not be so familiar to everybody because not all centers have a program of PDA stenting. So the golden standard has always been surgery. And as you know, PDA stenting would mostly be indicated for infants where we have a ductal dependent lesion. And the golden standard for that has been the classical Blalock-Taussig or a central shunt. So fortunately, since 2019, early 2020s, we've been having a lot of literature regarding PDA stents. And it seems like, and I'll just quickly, briefly look at these two, that compared to surgery, length of ventilation is definitely significantly decreased by ductal stenting, as well as hospital stay. And the question is also, these stents, because the one problem with the stent, it does not compensate for somatic growth of the infant. Does it do anything for freedom from re-intervention, survival? And you can see that the survival curves are, and the top ones are the ductal stent, is comparable to surgery. So what we know now from literature and looking at multi-center studies is that this is quite a viable alternative to the classical Blalock-Taussig or central type shunts. And I will basically stick to saying that in most aspects of treatment is definitely not inferior to surgery at this stage. So what then about these ducts? What do we have to know, or you have to know as pediatricians? Now, once again, it's very interesting that these ducts, there are almost 6 types, once again, described depending on the type of lesions. And they usually come off the descending aorta, but we get a lot coming off the vertically from the ductal arch or somewhere along the transverse aorta. And the problem with that being our standard femoral access, it's almost impossible to cross the angle with a stent, which is quite a rigid system. And you simply cannot make the angle, turning a simple, well, fairly simple procedure into something quite dangerous. So I think what has really changed are the new routes of access that we can use to get to these complicated PDAs. Having said that, one must remember that almost the same as for surgery, the re-intervention rate is about 40%, in surgery it's about 20–25%. But a lot of the re-interventions is one of the added benefits of implanting a stent in the duct is that you can actually enlarge it somewhat to compensate for, as I said previously, for somatic growth. So you can adjust the flow, get the child and the infant a little bit bigger. So what does it look like? We've had lots of queries about the access. Now, axillary access has become quite common nowadays for us in our unit when we do ductal stenting. And you can see on the X-ray, this is the forefront sheath from the femoral axis. You can see how easy the straight line to get into the PDA. And this child incidentally had bilateral PDAs with non-confluent pulmonary artery. So we stented the one from femoral because the angle was suitable, and this duct would have been impossible. You can imagine we would have required a 270-degree angle. So we did it straight through the axillary artery, but it looks quite impressive. If one hasn't seen this before, but the vascular complications are very few, and the children, initially I was quite scared about the children losing their arms, but it's a well-described route of access, and it's being used quite frequently and worldwide now. And the same goes for carotid access. And it's important to know the anatomy when one does it. We prefer to use ultrasound guidance, but it is quite difficult because the neck of it's usually newborns. It's actually quite short, but you need some guidance as to finding the vessel because the vessel is not always fixed and it kind of like jumps around. So it's a slightly different technique, and there is a small learning curve. But this is a duct that we stented through the carotid artery. We used the left carotid. You can see the absolute straight line, and here's the stent coming in the duct into the pulmonary artery. So a nice straight line. It's quick and easy. The procedure is much shorter, a lot less complications that one has to deal with. And then this is the standard transfemoral one. This is a child where we would expect it. Tricuspid atresia or pulmonary atresia, intact septum, usually have the standard type duct, which is quite amenable to access from the femoral artery. And there you can see the duct demonstrated in the first picture. And then the stent being in position, there's the stent inflated, and you can see there's good flow through the stent, and it's equal to surgery. What is very important, however, is that we have to cover the whole length of the duct. And if one leaves just one part of the duct unstented, it tends to constrict, and it's very difficult to get access that again after 2 or 3 days. And so you'll notice we always check that it just protrudes very slightly into the aorta, and you have to cover the duct as it enters the pulmonary artery. And we try and go just where it connects to the left pulmonary artery. But it's clear that ductal stenting is here to stay. It's becoming safer. It's becoming a lot quicker to do. And the child doesn't have to go to theater. And as I've shown in the beginning, your length of hospital stay is quite considerably reduced. The other advantages, of course, we have is that nowadays the new hardware that we have, and being a pediatric cardiologist, we kind of like love all our hardware, but we have new catheters. And one of the nice things are that we have new sheaths, and we're actually using a radial sheath nowadays, which is a lot thinner. It's almost a millimeter thinner than the standard 4 French sheath that we used to use. We've got much better guide wires. And then the stents stent technology has also improved. Just one thing that I have to mention is that we are using a lot more, because it's mostly coronary stents. And where we used to use cobalt chrome stents, nowadays we are confined almost entirely to using the new drug-eluting stents. But there have been quite a couple of studies to show that the dosage of the drugs are such that it does not really affect these infants. In any case, it's a kind of like, we only want to buy 4 to 6 months, same as with a blade octausic shunt after implanting a stent. But it's good technology, and if one sees it, one must know what it is about. And just one practical issue, what we find is that because the children do so well, the physicians and the parents think that this is the final procedure, and this is just part of a staging procedure. So it's imperative that one ask and remind the parents that they have to come back, because what we do find in about 20% of these stents is that they kind of like become stenosed over time because of ductal tissue protruding through the cells of the stent. But great technique. We are using it now, I'd say, in about 60% of children, locally, 60% of our children, we would rather implant a stent, and the other 40% we would still send for surgery, depending on the anatomy. Still, not all ducts are suitable for ductal stenting. And then finally, I want to end off this talk with the percutaneous pulmonary valve implantation and just bring you up to speed on what's happening. So the question is, how did we get to that? Well, we know that the problem is once we start operating, it's usually the post-operative tetralogies, double outlet right ventricle kind of like patients. And our treatment up to now surgically has been to put in a biological valve, either a homograft or a xenograft. Now, the problem is if one looks at the big series is that all of these have a limited lifespan, and the attrition rate at about 10 years for most biological valves are almost 50%. So we know we have to replace them. And if a second operation follows, the lifespan of that homograft is also quite markedly reduced. So the attrition rate becomes accelerated. And on average, if we just look at a standard patient with a, say, a tetralogy that was repaired and then had a transannular patch, had to have the valve replaced, over a whole lifetime, they would need about 5 surgical valves, which is quite considerable because as pediatricians, we never think that far ahead. Whilst, I mean, part of being a pediatric cardiologist is we have to think what happens in the future. And that's quite considerable to have 5 open heart surgeries over a lifetime. And that's the reason why this technology has evolved. So what do we know at present? We know that the mortality rate is almost similar or comparable to surgery. Our complication rate essentially the same. And freedom from re-intervention, where we're looking at homografts now, we are at about 50% or 30% of homografts requiring replacement at 5 years. We know we're almost the same. 70% of our valves will still be functional at 6 years. So it's quite comparable at this stage, what you can see. And there's just lately been data on the 10 to 12 year outcomes of percutaneous valves. And I can tell you it's 100% comparable to surgery and may even be slightly better. It seems like we're winning just about 1 year on surgery. So the big question is, in which patients can we do this? And I'll show you now why, but we cannot do this in very small children. They need to be almost at least 20 kilograms. It's mostly patients with either pulmonary regurgitation or pulmonary conduit stenosis. And obviously, they need favorable anatomy. We have 2 valves at our disposal, and the 2 percutaneous valves are the Melody and the Edward Sapien valve. And this is what it looks like. This is the Edward valve, and the nice thing, it goes in up to bigger sizes. One gets it in a 23 to 29 millimeter valve. It's made of bovine pericardium, and it's hand stitched onto a stent. It's quite a strong stent. And it's a fairly short valve, so the landing zone of this valve has to be quite exact, but quite a strong valve, and it's getting more into favor. The one that we most commonly use is,
I feel bad because I'm probably so mean to guys. So it's just like, guys, no, there's a rule. Like, we never act like actually.
Yes, we have somebody on the, it's the Melody valve. Which is a bovine jugular vein sewed onto a stent. And this is the most common one we're using. And it's the same as a Contegra, which is surgical. The reason being, as I mentioned, why bigger children is that the delivery system, and the Melody valve has got the smallest delivery system. The Edwards valve is a 25 to 26 French system. The Melody is a 22 French system. So it's quite a big delivery system. And it's simple to explain. It's the thickness of the valve plus the thickness of the stent. But what one has to do, one of the biggest risks is coronary artery compression. And so one has to investigate these patients quite extensively. And it's very important to have either a very good thin sliced scan or an MRI to correlate the spatial anatomy of the coronary arteries compared to the pulmonary arteries. So not all patients are suitable for this procedure. And in essence, the plan is that one goes in through the groin, enters the heart, go through the valve, and then inflate the balloon, and the stented valve is then left behind. And this is what it looks like in real life. It's the Melody system. This is what the valve looks like when one gets it out from the bottle in which it's being dispensed. It has to be crimped onto the system. You can see how thin it gets eventually. And this is what we do. This is a patient that was referred. You can see the marked calcification. And one of the reasons why the surgeons didn't want to do this patient is because of the fact of the absolute retrosternal positioning of the pulmonary artery, which means the moment they open the chest, they will cut directly into the heart. And if this child's not on a fem bypass, the patient will not survive. So we're seeing a lot of these patients who had conduits, and you can see how the calcification, how strong it is. And this is the first stent. We usually implant 1 to 2 stents to create a landing zone, because you need a stable landing zone to prevent fractures of the stent of the valve itself. And in this patient, to give you an idea, we had to use a 14-atmosphere balloon eventually to crack the calcium, which one can see. And let's go on to the next slide. And here's the delivery of the valve. You can see 2 stents. You can see the nose cone of the Melody valve. And here's the valve being inflated. And then one has a patent valve afterwards, the same as surgery. The procedure takes about roughly, depends on how difficult it is, 2 to 4 hours, and the patient can essentially go home the following day, which is the way in how one saves costs, because, and one has to, it's a question that often comes up. So how expensive is it? Now, the valve itself, valves itself, they around about 20 to 22,000 US dollars. And then obviously the theater time, etc. But ballpark figures, it compares almost, it's almost the same as open heart surgery at this stage. So it's not cheaper. Where we have some advantage is the short-term hospitalization and the morbidity. I mean, they can basically go back to school within a week or so, but I mean, they go home after 1 day. And I want to conclude by just, as I mentioned, there's always complications. The most dangerous complication of a pulmonary valve, and that's why we do such extensive workup for these patients, would be coronary compression. And virtually all the deaths in the world has been as a result of coronary compression. It has decreased markedly because we know now how to try and avoid it, but it's still a significant risk. Obviously, the valve may embolize, and one may get perforation of the pulmonary artery causing acute pneumothorax. So, and for that reason, we always have a surgical team on standby. But I think we're moving into a new age. Pulmonary valve replacement and percutaneous pulmonary valve replacement is here to stay. And just to show you finally is how we think, and I'm sorry, I'm 3 minutes over my time, just to show you what happens. Now, if we look at the right ventricular function over time, and this is for a normal patient, what happens, all of us, our right ventricle, the function will decline as we age. It's a normal process. The problem is when you have a tetralogy, and especially if you have pulmonary regurgitation, your lifespan is decreased because of this. So what they saw, patients, once they started operating patients, and that started in the mid-60s, and they put transannular patches. And then what they noticed, oh my goodness, when they got into their 20s, all of these patients became significantly symptomatic with right heart failure. So they waited until patients got symptoms, replaced the pulmonary valve with a homograph, waited until the patient got symptoms, and we know that the survival rate was markedly decreased. And then in the mid-80s, the new kind of like current method of treatment kind of like took place, because people noticed that we have to intervene earlier in these patients. Put in homograft, you improve the function, but over time, there's an attrition rate, as I showed you, with the homografts becoming even more stenotic or more incompetent, the valves, and they replace them. This is how one gets to about 4 to 5 open hearts over a lifetime. But where we see pulmonary valves now, it gives us the advantage. What we can do, we can intervene a little bit earlier because you don't have to operate. There's no bypass involved, and we can replace it. But the idea is, and the same, replace it and then eventually perhaps surgery. But the idea is to move this curve closer to normal, because that in the end is what we as physicians should be aiming for. And just a last thought, perhaps what we should do, there's no scientific evidence, but I think we're moving there, is that we take a younger patient, stent the outflow tract, because we know that pulmonary regurg is tolerated well in the first 1 to 2 decades of life. Stent it and then replace a valve, in order to minimize it. And probably then put in a percutaneous valve, delay surgery until later. But this is kind of like new age thinking, and this new technologies, new developments hopefully will get us there, so that, and I repeat what I said, we aim to get our patients and quality of life as close to normal as possible. I thank you all for listening to me, and I hope this shed some light on what we're doing as pediatric cardiologists. I didn't want to overwhelm you with all the defects, that we could do this or that at a later stage, but I think it's good to know what we can do, what's new, and what's really exciting for us as pediatric cardiologists. So I thank you for your time.
Steve, thank you for an excellent presentation. You really have nimble fingers and nerves of steel, quite a combination. I'm going to ask the chat group if anybody has any questions before we move on to the second speaker. That was really a very fascinating, amazing what you can do in the cath lab. Guys, feel free to type in the chat box, or you can unmute yourselves and ask a question. Steve, it looks like you've stunned everybody.
I so hoped it was going to be simple. No, it's just because it's so new. I think it's nice just to know where we're going with this new technologies and what we can do. And I'm not sure whether it is available in all units at present.
I think it's stunning work that you guys are doing. I'm always in awe of interventional cardiology. I think it's amazing. We rely on our cardiologists a lot as well to do even some renal artery work as well. So thank you very much for a fascinating presentation. And I'm sure a lot of people are going to have you on their speed dial. So watch this space.